So good evening, ladies and gentlemen. I am Dr. Neha Jain, and I welcome you all on behalf of MCure Pharmaceuticals Limited to this wonderful workshop of the No Thrombosis series in acute ischemic stroke. It's my proud privilege and honor to have with us the stalwarts of the country supporting us in this initiative. I would first like to welcome and introduce our course director, Dr. Subhash Kaul sir. Sir is a senior consultant and stroke specialist at KIMS Secunderabad and also the chairman of KIMS Foundation and Research Center. Sir was a faculty for over 27 years at Nizam's Institute of Medical Sciences, Hyderabad, and also the former professor and head, Department of Neurology and Dean at NIMS. Sir has over 120 publications in reputed journals across the globe. He is a principal and co-investigator in several important projects and trials, including the single largest Hyderabad Stroke Registry funded by ICMR. Sir has been the president of AP Neuroscientists Association in the past, a president of Indian Stroke Association, and also the president of Indian Academy of Neurology in the past. I now welcome and introduce our moderator, Dr. S. Meenakshi Sundaram sir. Dr. Meenakshi Sundaram sir is a senior consultant neurologist at Apollo Hospitals, Madurai. He brings with himself over 2 decades of experience in this field. Sir has presented papers at prestigious national and international forums, and he has also received the Best Research Paper Award at the 10th Annual Conference of Indian Academy of Neurology held in Lucknow in 2002. Sir is the principal investigator of many important trials, such as the refractory partial epilepsy, the stroke trial, and the Parkinson's disease trial. Sir is also the editor of the South Asian edition of book on practical neurology by Jose Biller, Walter Kluwer, of December 2020 edition, and he has also contributed to many other books on neurology. I now welcome and introduce our second moderator, Dr. Nirendra Kumar Rai sir. Dr. Nirendra Kumar Rai is a senior consultant neurologist at Neurocity Bhopal. He is an ex-additional professor and head of neurology, AIIMS Bhopal, a founder faculty of Department of Neurology at AIIMS Bhopal, and he has also done a fellowship in intervention neurology from Zurich, Switzerland. Sir is a university gold medalist for the best resident doctor at BHU Varanasi. He is a member of various national and international academic societies and also a principal investigator and co-investigator of various extramural funded research projects. I now welcome and introduce our key speakers for today's session. Our first speaker is Dr. G. Ranjit. Dr. G. Ranjit has done a postdoctoral fellowship in stroke and intervention neurology under the renowned neurointerventionist Dr. G.G. Kurtukulam. He has worked as consultant neurophysician and intervention neurologist at Apollo Hospital, Secunderabad in the past, and he is presently working at Medicover Hospitals, Madhapur since January 2021. He will be presenting an interesting case on bridge or not to bridge. I now welcome and introduce our second speaker, Dr. G.V.K.R. God. Dr. G.V.K.R. God is a consultant neurologist at Dr. G.V.K.R.'s Neuro Center, Mehboob Nagar. He has thrombolized over 50 patients of acute ischemic stroke, and he holds an expertise in managing stroke emergencies. He was awarded with the Best Paper Award in TNS Con in 2020, a Best Poster for National Epilepsy Conference in 2019. He is also awarded a Best Case Presentation in OSME Con for Sturge-Weber syndrome in 2010. He'll be presenting an interesting case of Sunday thrombolysis. With this, I would now request our course director, Dr. Subhash Kaul sir, to give us a brief overview of the program and his opening remarks.
Yeah, Neha, thank you very much. I think you have already set the stage. And once again, I have to thank MCure and thank you for organizing this event month after month. As all of you know, that stroke or for that matter, any other field of medicine is constantly changing, constantly changing. I think medicine we have to read like we read newspaper. It's not enough to say that I have read newspaper yesterday, but you haven't read it today. So there's no value for yesterday's newspaper. Same, I think medicine is also changing at that speed. And whatever guidelines and rules and textbooks you are reading, they're already 5 years old. Already 5 years old by the time you see them in the journal. So therefore, this current experience, online experience, current experience, what happened yesterday, what happened 1 hour back, is also important for us to learn. Because as Miller Fisher said, you learn neurology stroke by stroke. So this is very important. And I think in that, this forum which you have created by which everybody shares his experience is extremely valuable. And in the last few months, we have learned so much. At least I have learned so much from my other colleagues. So with that, I welcome our very renowned Dr. Meenakshi Sundaram, who is an expert stroke specialist himself and an excellent quiz master. He knows all the questions and all the answers. So I request him to please take over the session and carry on the proceedings.
Thank you very much for the kind words, sir. I know the questions, but not the answers. That's the only thing which I need to tell, sir. Sir, we'll straight away, without much ado, go for the cases. If our other colleague also has something to share, he could share, sir, and then we can go. Dr. Jha.
We'll request
Dr. Rai, sir, would like to share something. He can share. I have nothing.
Sir, Dr. Rai, sir, is just joining us in a moment. We just checked with him. He's probably in some emergency. He's just joining in a moment. Meanwhile, we can start with Dr. Ranjit's case.
We're very excited to have this because it's a very hot topic he has chosen. Bridge thrombolysis has been the subject of debate in many forums now. So thank you very much, Dr. Ranjit, for choosing it. And thank you, sir. Thank you, all, sir.
Yeah, are my slides visible?
Yeah.
Good evening, sir. I am Dr. Ranjit, consultant neurophysician, and I'm doing interventions also in Medicare Hospitals, Madhapur. It is my privilege to talk before Subhash Kaul sir and Meenakshi Sundaram sir. So today I'll be presenting a case where I have thrombolyzed and I have taken for mechanical thrombectomy. So he's a 65-year-old male, known hypertensive and coronary artery disease. He underwent PTCA previously, and he was admitted under cardiology with hypertensive heart failure, for which he was treated and was about to get discharged. On the day of discharge, patient developed sudden onset inability to speak and weakness of right upper limb and lower limb. He had old history of acute ischemic stroke with left hemiparesis 5 years back, from which he recovered completely within 1 or 2 months. So since then, he is on dual antiplatelets for his stroke and also for his coronary artery disease. On examination, he was having left preferential gaze, global aphasia, right upper limb power was 0, and he was barely able to move his lower limb, right lower limb. Left upper limb and lower limb power was good. And his NHS score was 22/42. So he was taken up for MRI stroke protocol, in which it was showing only left ICA, right ICA was not seen, maybe a CTO, and there was left M1 occlusion, for which he was symptomatic. So we can see early ischemic changes, diffusion restriction changes in the temporal lobes, in the caudate nucleus, and in the lentiform nucleus, and the tail of caudate nucleus. So patient was given injection Tenectase 0.25 mg per kg body weight, total of 17.5 mg IV stat, followed by which he was shifted to cath lab for mechanical thrombectomy. Onset to IVT time was 90 minutes, a bit prolonged. Onset to groin puncture time was 2.5 hours. This is the left ICA shoot. So this left ICA shoot is showing two things. One is left ICA is very important for the whole of anterior circulation of this patient, because it is providing to right MCA, right ACA, left ACA, and here we can see left proximal M1 occlusion. So this left ICA is the access artery through which we have to do mechanical thrombectomy, and we should be careful with this left ICA access artery and not injure that artery, because almost whole of the brain is supplied by this left ICA. So I did this mechanical thrombectomy with Solumbra technique, and here there was stent aspiration catheter. I could negotiate only up to terminal ICA, And stent retriever I could deploy into the thrombus in the MCA. This is a stent retriever. We can see the stent struts here. This was the initial shoot, and this is the shoot after 2 passes. I had to do 2 passes, after which the vessel got recanalized. We can see good distal flow after the vessel got recanalized, although a very small thrombus is remaining here. And even we can see lenticulostriate arteries coming out from this proximal M1, which we are not able to see here. So lenticulostriate arteries got open, and even the whole of MCA got open. And on table patient's power improved, but it took some time for speech to improve. CT brain was done 24 hours after the thrombectomy, and it is showing anterior temporal hypodensities and high parietal hypodensity here. Majority of the tissue was salvaged. He was discharged on day 5 with NIHS of 3/42. He was having mild word finding difficulty. Motor power was good, but he was having mild word finding difficulty.
చెప్పండి ఎలా ఉన్నారు? చేతులు పైకి లేపండి, 2 చేతులు పైకి లేపండి, మీదికి 2 పైకి లేపండి, మీదికి మాస్క్ ఇక్కడ మీదికి వెళ్ళు దగ్గరికి వెళ్ళు ఓకే దగ్గరికి రండి నడుచుకుంటూ.
I am hoping that he'll improve more by the end of 3 months. So, 1 second. Yes. So this case was taken up after intravenous thrombolysis, and it was recanalized with the help of mechanical thrombectomy. So how many cases we see which get recanalized with the intravenous thrombolysis and which need mechanical thrombectomy after intravenous thrombolysis? So this mechanical thrombectomy was done after 1 hour of injections were taken 1 hour after intravenous thrombolysis was administered. So I want to see what the literature is telling. So this is Extend 1A TNK trial. In this trial, they have compared tenecteplase and alteplase in large vessel occlusions given from 0 to 4.5 hours of thrombolysis. So total 202 patients were enrolled in this study. 101 were given tenecteplase and 101 were given alteplase. So it showed non-inferiority of tenecteplase, and also tenecteplase was a bit superior in recanalizing the blood vessels and achieving 2B/3 recanalization before mechanical thrombectomy. Mechanical thrombectomy was attempted also. So, which was defined as absence of retrievable thrombus at initial angiogram. About 22% of patients had TK2B3 recanalization in tenecteplase group, whereas 10% of patients had this recanalization in alteplase group. And symptomatic ICH was less in these patients, only 1%. And one more study, TNK Extend 1A Part 2. In this, they have compared 0.25 mg tenecteplase with 0.4 mg tenecteplase, where the recanalization rates were same in both the doses, 19.3% in both the doses, but the symptomatic hemorrhage was a bit high in 0.45 group when compared 0.4 group when compared to 0.25 group. So about 10% to 20% of patients will attain recanalization with IVT in large vessel occlusions. In the studies like TNK Extend 1A and Extend 1A TNK, IVT was considered safe in large vessel occlusions, and especially TNK has shown about 18 to 20% of recanalization rates with improved early neurological recovery. So I wanted to signify that TNK can achieve about 20% of in 20% of cases recanalization. Although there are many studies coming in support of direct thrombectomy. In our setting, in Indian setting, where most of the people are affordability issues will be there, and whether these patients will turn up for mechanical thrombectomy or not sure. I strongly feel that Tenectase can be administered in all the eligible patients. IVT should be administered in all the eligible patients from 0 to 4.5 hours. Yes, sir. Thanks, sir. Thanks, sir. End of my case, sir.
So, can I make a comment?
Yes, sir.
After Tenectase IV, first of all, it was a very good presentation.
Thanks.
We'll start from that. This was an ideal case.
Yes.
You have just followed the rules very correctly, and fortunately, patient has done well because he came in window period.
Yes.
He was not a minor stroke. He was not a devastating major stroke. Also, he was just what it should be, what a good stroke should be, moderate stroke, right?
Yes, sir.
And you gave him Tenectase within the window period, and then because it was a large vessel occlusion, you thrombolized him mechanically also, did a thrombectomy, and the outcome was good, very good. And it was a difficult case because of the contralateral occlusion. It was a high-risk case, but you took the case. So this is perfect. Now, I have one or two questions. After IVTPA, Tenectase, TNK, after IV TNK, when you were doing mechanical thrombectomy, by the time, had it recanalized or no, it had not recanalized?
No, sir. In this case, it did not recanalize, sir.
Yeah.
So this was the first slide, which was showing M1 occlusion. This was the first angio picture, sir. And this is the second angio picture.
Yeah.
After doing mechanical thrombectomy, it got recanalized, sir.
Yeah. That is very good. In fact, we don't have to wait to check whether it has recanalized or not. The recommendation is that in a large vessel occlusion, exactly what you have done. In a large vessel occlusion, you give IV thrombolysis, and then if it's large vessel occlusion, just take him straight away for mechanical thrombectomy. Sometimes you may get a surprise that the vessel has already thrombolized. That's why I asked this question.
Yes,
and in that case, it doesn't matter. You just close your procedure and don't do mechanical thrombectomy.
Yes,
it will happen in many patients, particularly as claimed in Tenectase.
Yes, sir.
But still, in order not to waste time, you don't have to do a check angio or something. You just, after giving IV TPA, you just go for mechanical.
Yes.
Now, so case is great, and I think Meenakshi will give his comments. But I just want to share you some new findings which were presented in the American Stroke Association meeting, which was held only 2 weeks back. No. I didn't attend the meeting, but I came to know through the media that one thing they have done is that papers are presented on the use of intravenous Tenectase up to 24 hours. That is really, that's going to change the whole scene. Alteplase has been tried up to 9 hours based on perfusion data. And there's a study which was presented of intravenous Tenectase up to 24 hours. And they are testing 2 doses, 0.25 and 0.32. So there is something to look forward to. If it happens, it will be great. And the second thing which was presented there is that, for mechanical thrombectomy, we always don't want a very big infarct. We don't want aspects to be less than 6. That's what it is, even within 6 hours. But they are now, one study was presented there where they have said that you can take any extent of the infarct, even if the entire MCA, you can do it. The trial was presented and the results were not bad. So now they are going to go further. So some very new things are happening in stroke, but your case was excellent, and over to Meenakshi for his comments.
So thank you, sir. Am I audible, sir?
Yes.
Yes, sir.
Sir, thank you very much for pointing to this very important study, because that was the Chinese study, the Chablis study that was presented there. So it's really exciting for all of us, because now perfusion-based thrombolysis could be done in selected patients with tenectase up to 24 hours. That should be really a great this one for us, because alteplase could be used up to 8 to 9 hours. That has come already. The data is there for us. So we are in fact using it to remain on the right side of the law. We use perfusion-based thrombolysis IV up to 8 to 9 hours. We use it alteplase. But now, if this comes, I think tenectase will have a long rope for us. Now, there's a great case really, because the NIH stroke scale of 22 and then walking out with 3 is phenomenal, I must say. And your technique should be fantastic, really. The recalization is really awesome, sir. Really fantastic, really. You are just, really wonderful. Now, there are 5 things which are talked about why we can go directly in favor of mechanical thrombectomy, because they are the recent data which has come of the DEVT trial, direct trial, or direct EVT trial. All those things, the skip data from Japan, all of them, they say you go directly for MT. And why they are saying so, we have to really ponder over those data also, because there are 5 things which are pointed out about the utilization where they say direct MT could be used. The first thing, what is their argument? They say it could delay MT. If you give IV and then go further, there could be a delay. But with tenectase, we don't have that problem at all, because you just have to give a bolus and go, because because all those data are coming after the usage of intravenous alteplase, if I'm right. So it's not going to be, the same for our tenectase. The second thing they say is that the substantial cost, that's always mentioned there. But again, when we look at that, I'm sure this MT procedure which we have done is not less than 4 to 5 lakhs, because the catheter is so expensive. Yes. When a person is going to spend 4 to 5 lakhs for that utilization of that catheters, might as well give another 20-25,000 extra initially to see whether it recanalizes without that also, because you have shown that in a good number of people, at least almost 1/5 or 1/4 of patients in that data, which is shown extent TAK trial, that they are opening. So it makes sense, in my opinion, to use IVT before, whatever the data they are claiming, that you do directly MT. In our hospital, we follow the same protocol. We always use tenectase before they ask anything. In fact, now our consultants, the emergency, are smart. They don't even ask us for tenectase. They finish it, and then they immediately, when they are calling us, the tenectase is ready with them. So that's a good thing to do. It saves a lot of time for all of us. If at all the delay happens, is because the patients have to sign the consent. That's the only thing which delays for us. Otherwise, there's no delay otherwise. Then they always talk about the third thing. As I said, one is the cost. Second, the delay. The third thing is that whether it is worth to give for that small percentage. You have shown that almost 1/5. It's not a small percentage, large percentage. The fourth thing is that whether it will increase the chance of intracerebral hemorrhage. And we all know tenectase, by and large, when compared to alteplase, there is a lesser instance of hemorrhage. And finally, they talk about the thrombus fragmentation. They say that the fragmentation could go and distally occlude something and produce trouble. I do not know how much, it's correct. We'll ask Subhash Kolsar or Dr. Roy, sir, they could comment on that, whether distal fragmentation, but in our experience, we are not seeing this. So we give IV tenectase. In fact, we always believe, that's why sir asked you how it was when you took the first shot. We have seen that once you have softened the clot by administration of your IV thrombolytic, then it is easier for us to go through, and we can go through that, we can navigate it better. So I always favor the same IVT followed by mechanical thrombectomy in almost all my patients, and is also beneficial because there may be microvascular thrombosis distally also. We only open up the large clot and we'll be leaving out those things. And for that, we have found this, and your reports were superb. You're very lucky. One thing is that though the deficits were more, the infarct was not too large on your scan initially, and you could do it immediately and could come out. Really, congratulations, sir. Fantastic case, really. Thank you very much.
Since the topic is on bridging, there is very interesting data from the same conference, because we have all been reading about the proceedings of the American Stroke Association. I think this discussion about bridging, means whether we should do both together or we should do direct thrombectomy, has come to a very interesting stage now. It's come to a very interesting stage. it says that if you leave the cost aside, that is one issue. But we are talking of efficacy and safety. They say that when you combine the two, bridging is effective, but not a whole lot effective, little effective. The advantage of bridging is little more effective than mechanical alone. Mechanical is very effective, almost 80% or 70%. But when you add IVTPA, it becomes a little more effective, not a whole lot effective, right? And in fact, that is the argument of the mechanical people, that you don't add much to it. That is the basis on which they want to do it alone. Now, as far as the hemorrhage is concerned, when we have to be on the side of the IV people, the hemorrhage is not much when you combine the two. So when you combine the two, it's not all that bad. And when you give it alone, again, it's not all that bad. So you can do any one of them. But the guidelines are still going bridging only, as far as guidelines. As per the guidelines go, you can. But suppose tomorrow you do mechanical alone, you can justify that. You can say, I thought that in this patient there was a risk of hemorrhage or cost was the problem, therefore I went directly. You can justify that because the advantage is not that huge. But on the other hand, if you give both together, you are on the side of the guidelines. So I think this is a very interesting stage. We'll see. It's like elections. We'll see now in next 1 or 2 years which way the trials go. The fight is going on in the international arena. But now the gap between these two is very narrow now, almost very narrow. Because they are saying you don't get much advantage by combining the two, but there is an advantage. There is an advantage by combination. And as far as hemorrhage is concerned, no, that risk is not there. Don't give that explanation. They have seen the hemorrhages don't occur because of IVTPA or IV tenectase. Hemorrhages occur because of recanalization, which will happen by thrombectomy also. So that is what I gathered from the latest conference. But great, your case was great. It was ideal as per the guidelines.
Yes.
And another good thing about your case was that I said it was a moderate. No, it was a moderately severe case. 22 means, 10 years back, I would not have thrombolized such a patient. With 22, I would have been afraid. But here you could bring it down to 3. Congratulations, Ranjit. Great job done.
Thanks, sir.
Dr. Rai, sir, would you also please like to share your thoughts on this case?
It was really a very interesting and very case managed very nicely. Calls are covered everything nicely. And earlier, Sundaram sir also described it. One thing I just want to add, few patients I witnessed in Zurich also, and sometimes also when we give IV thrombolysis, it gets recanalized even without mechanical thrombectomy. So I also believe that IV should be given first, and then as other experts described, and then a mechanical we should go. And because sometimes we are arranging in India, we are arranging something, so it may take 90 minutes, 60 minutes for mechanical thrombectomy. So this window period or this important period can be taken care by tenectase when we are giving only a push dose. This is
one more question I want to ask you, because you people we are neurologists, we have interventional radiologists doing it, but you people are actually doing it. So there is a question that's always pops up in mind. Our interventional radiologist says that once the patient has received tenectase, after that he is having an ease of passing the catheter. The number of passes required is much less, even in occlusions where he initially thinks it might be difficult. Is that true with you all also, sir?
Sir, basically, I don't feel any difference is there from the groin puncture site to the recanalization sites with or without thrombolysis, sir. Even if we take literature tells that groin hematomas may be high with intravenous thrombolysis. I never encountered much of groin hematomas with intravenous thrombolysis, and there was no much difference in the passage of catheters or the recanalization rates with the with or without intravenous thrombolysis, sir. Most of the times, it depends upon the characteristic of the clot, sir. If it is a white clot, it does not come out easily. If it is a red clot, it comes out easily. But one thing is, distal fragmentation, I did not see, sir. With the IVT, distal fragmentation, I did not see much.
I think this patient's underlying vascular disease may be a intracranial atherosclerotic disease, because even after this, you can see some irregularity there.
Yes, some irregularity was there. I did not want to chase that one, sir, because patient.
And these patients, probably simple IV thrombolysis is not enough to lyse that, because their walls are very shaggy and all, as opposed to cardioembolic.
Yes, sir.
They are very soft, they dissolve, but these ones are very difficult.
Yes, sir.
So it's a great thing which we have done,
What pushed him to this stroke?
Sir?
What pushed him to this stroke? He was all the way okay with the right side being, completely ICU, being occluded, left side giving everything. So suddenly, why did he develop this massive stroke?
Sir, what I
was
felt,
it a precipitating feature?
The precipitating feature was hypertension, sir. Accelerated hypertension, heart failure. He was admitted actually with hypertensive heart failure, sir. There might be, as sir told, I also felt that there might be a bad intracranial atherosclerotic disease, and the plaque would have ruptured and it would have got occluded, is what I thought, sir, because of accelerated hypertension.
Meenakshi, that is your question, no? It was not COVID.
So he did not have COVID, sir.
I mean, Meenakshi, this is the answer to this question nobody in the world knows. And I would be very happy if somebody shares that what happens on the day when a patient gets stroke. Risk factors have been there all the time. Intracranial disease is there all the time. Then what triggers on that particular day? If we could get hold of that, we could just prevent stroke, but we don't know really that what happened on that day. What happened? In some cases, things maybe there you missed the aspirin for 6 days. But short of those direct triggers, it's very difficult to know that, we say that the aspirin resistance, but that resistance doesn't happen on every day. The patient is all right for 1 month, and then on 31st day, he gets a stroke. So that is a big area of research that your question, what happened, what precipitated, what caused, that is $1 million question. I think someday maybe in this forum, somebody will teach us that. Yeah.
Sir, I'm just thinking about it, but it's something that only if you know the stroke is about to happen to a person, only then you can, be alert and try to decipher what's going on, what are the dynamics going on in the head or overall systemically. It's just the unpredictability of stroke. So many times, sir, you talk about the risk factors, stress, getting agitated. But so many times patients are just like when they're sleeping, they're totally calm.
Yeah.
Yeah, and I wish that someday even we all are here to get more insight into it. But looks to be very difficult, because how to create that sort of a study design is very difficult. But yes, very rightly said. Nobody knows what goes on in the body. Exactly.
Sleeping is also not always calm, because REM sleep may be having some paradoxical events also. So sleep also, there is a whole lot of dynamics going on.
Very true, sir. Very true. So is sorry, sir. Please.
No, nothing. Please.
So is the case with MI also, no, sir? I mean, again, the thrombolysis, the person must be having the blocked arteries for a while.
Yeah.
And there are so many people who incidentally, they just happen to, we happen to find out that their RC was blocked or this and that, and they have been asymptomatic. And so what exactly happens that blocked artery suddenly, you get an MI. So yeah, maybe, sir, can we move on to the next case, sir?
Yes, please.
Yes.
I have just one incident there. One of our cases, admitted as cardiologist, ischemic heart disease, placed on prasugrel and discharge. Aspirin, prasugrel, discharge after angioplasty, post-angioplasty. He was just getting into the car and he stroked and he came inside. And then we thrombolized him. That day it was IV thrombolysis with the altiplase we used, and the patient became better. And he also had a bleeding also. But when they asked what was the reason for stroke, my colleague, when I presented this, he said, why did he have a stroke suddenly? He said he saw the bill. That's what
he saw that? He saw what?
He saw the bill, sir, when he was discharged. He stroked.
Sir, I tell you, yesterday we had one of the programs going on, and one of the young neurologists from Mumbai, he told about a very interesting case. He said many times you have to counsel the patients, telling them that we'll give the drug, but there are only 20 to 30% chances of complete recanalization, and we will see. Then we may require a procedure, invasive procedure like mechanical. And he said that I had a patient with stroke and we thrombolized, and we had primed the patient party on the other side, but the patient completely recovered. There was complete recanalization. Patient improved. And then we went and told the party that it looks to be a miracle, patient is all well. And right when they were discharging the patient, he got a stroke again. And then it was so difficult for them to go back and explain it to the patient's family that now how this has happened. They were like, you said that the patient is fine. You said that the clot has gone from the brain. Now how could this happen?
Had they shown the bill to the patient?
No, sir. We had not gone to that level of discussion. But it's so difficult a situation. The unpredictability only a neurologist can understand. We'll move to the next case, sir. Dr. Yeah.
Yes, madam.
Dr.
Please go.
Next case.
Hello, sir. Hello, sir.
Yeah, please go ahead.
I'm not able to share my screen, sir.
Would you like to send your slide deck to me, Dr. GVKR?
Yes.
आप
Just-
मुझे mail, yeah, I'm just sending you my email ID in the chat box. Is it too big a file or?
No, it's just 3 MB.
Yeah, please send me. I just sent you my email ID. So it's small and that's by mistake.
Sure.
Only. Just send me, I'll download and present from here. Gone?
Yes.
Yeah, I'll just.
I'm doing it.
Give me a minute. I have not received it. Just give me. Just 2 more minutes. Can you try sharing from your end once more, Dr. Gaud? Meanwhile, I'm just trying to, the mail is still not received in my inbox. Not received, Dr. Gaud. Can you try sharing from your end once again, please?
I'm doing it.
Yeah, or you can share me on one more ID. I'm not receiving it. I've refreshed my page, but not receiving it so far.
Okay. Did you get that? Just refresh. I've sent you.
You're not able to share what? What is the issue?
I'm not able to share my screen actually.
Why? You don't have the rights? No, I mean, all of us can. You can. Are you the?
I'm not sure.
Okay.
Like,
no, but I think Dr. Ranjit could do. So I'm not receiving your email. What do I do?
I have just shared again to the other ID also.
Send it to me on the other email also, doctor. I sent you 2 emails. One is the Gmail account as well.
Yes.
Yeah, I just probably received your email. Yeah. Yeah, I'm just downloading it. I'm sure.
Yeah, it has come.
Yes.
We are good to go. Yeah.
Yes. Thank you. Sorry for the delay. So the title actually goes with Sunday Thrombolysis. So it all started at 11 a.m. Meanwhile, I'm Dr. G.V.K.R. Gaud. I have finished my DM Neurology from NIMS recently, and I've been practicing for the past 6 months. So this is like my 5th or 6th case, 5th thrombolysis. But I feel that out of all the 6 thrombolysis that I've done in the last 6 months, these 2 are most interesting for me. And at 11 a.m. on Sunday, I got a call from ER. He was a 70-year-old male. He was happily retired, but he was hypertensive, but on treatment. And he was on, while he was doing his household work, he suddenly stopped doing it. And he called his wife that he was not able to see anything. Like he was totally blank and it was all black. So it was completely dark. And this episode was followed by severe vertigo. So this was the preceding day of this symptoms. He had an atypical chest pain for which he contacted a nearby doctor. He was given some medicines which he did not take. So he had to rush to the hospital. Next slide, please. So on examination, he was conscious and coherent. His BP was 210 by 100 millimeters of mercury, and he has a complete visual field defect. And as far as the NIHS score is concerned, it was only the vision that was affected. So it was only 3 by 42. So, sir, is this an interactive session? Like, can we interact, or should I just proceed further?
At the end of the day, at the end of the case, maybe we'll open it for discussion if it's like that.
Yeah. Okay. Fine.
He wants to ask questions to us. That's what you want to know.
No, sir. I mean,
absolutely, you could ask. Sir.
If there are any students in the community, maybe
we are students. Sir. You can throw it to us.
Sir. So my first instruction to the ER team was to reduce the BP. So we gave him a shot of labetalol and tried to bring down his BP. And moreover, it was just a visual complaint, and even the ER team was confused, like whether is this a neurological symptom or just a headache, because patient was not clear whether he had an headache or just a vertigo that was because of which he was not able to see, or is it the real blindness? So keeping in mind the atypical chest pain which he had on the prior day, I asked for an MR. So we got an MRI done. So next slide, please. So next slide. So we got an MRI done, and here we could see there is a diffusion restriction with ADC. ADC is there, ADC reversal in the right posterior circulation. So we have thrombolized him. We gave him tenectase at the rate of 0.25 mg per kg after stabilizing the BP. Next slide, please. So as a general guideline, if the NIH score is less than 5, maybe we can just withhold. But please, next slide, please. But there is also a indication, even where the NIH score is less than 5, if there is complete hemianopia of more than or equal to 2 on NIH question 3, or if the disability which is severe or which can severely affect the patient's further lifestyle, then it's a indication for thrombolysis. So we went ahead with IV thrombolysis. Next slide, please. And now we have thrombolysis. Here the most important point was the patient came to the hospital within 30 minutes from the onset of the symptoms. And from here on, as our center did not have MRI, and I was more keen to look at the like to make sure was a good option or not. So I went ahead with the MRI, but luckily we could get it done in 60 minutes. Thanks to the team in our ER, so that we could thrombolyze him within 60 minutes, including the time that we had to take for the to procure the drug. So finally, he was thrombolyzed at around 12 noon, and by 3 p.m. when we had it's like without hello. Yeah. Hello.
Hello, Doctor.
Hello. Is it audible?
Yeah, now you are audible.
Is it audible, sir? Hello.
Now it is better. Yeah.
Yeah. Yes, sir. So at the time of discharge, patient was able to his right visual field has completely recovered, and even in the left visual field, he was able to perceive hand movements. And patient came back after a week for follow-up, and now he's able to just identify the structure. Like he's able to identify the 2-dimension of the structure, but and also few contrasting colors. So I think he should be better in a month or so. This is one case, sir. And on the same day, and again 10 p.m. in the night, and the 2 on Sunday, I got another call. And this time it was like 54-year-old. He was de novo detected hypertensive, and he also presented within half an hour of the symptom onset. And this time he presented with sudden onset of slurring of speech, and also with weakness of left upper and lower limb. Next slide, please. And on examination, he was conscious current. His BP was 170/100, and he had left human facial palsy and also left hemiparesis. His NIH score was 7/42. So again, we did not have the option of CT within the center this time because this was in another place. So we had a like dilemma whether to go for CT or MRI. But again, I chose for MRI because both of the it was just a matter of 5 or 10 minutes. I thought I could decide better based on the pictures of the MRI. So we got an MRI done, and that was showing infarct. Next slide, please. Infarct in the right putamen and also internal capsule. And next slide, please. And we have given IV thrombolysis this time with Tenectase. Here also we could manage to keep short the door to needle time within 45 minutes. That includes the counseling part. But this time I have made sure that the drug reached the time well before we had those images in hand. So at the time of onset and before the injection was given, he was like he had near total human facial palsy, and his upper limb was power was 2 and lower limb power was almost 1. But just the day after the thrombolysis was done, he was able to walk. I think this is a video, but yeah. You can just click on the video, please. So here he was able to walk by himself, and he was very happy that he was able to walk by himself, and he was able to eat with his own hands, which he was not able to do the other night. That's all, sir. Thank you, sir.
I think those are great presentations. Both of them came on Sunday?
Yes, sir. Both of them on the same day, sir.
I think the most difficult thing was that they came on Sunday.
Yes, sir.
Rest of the decisions were easy to take. But the difficult decision was Sunday or Saturday afternoon.
Yes,
but, I just make 2 short comments before I request.
Okay, sir. Okay.
One of the things which I found is that you very rightly put a lot of emphasis on door to needle time. And
Yes,
that is a very good concept. And in fact, the a stroke unit is thought to be very efficient if at least half of your patients, not all, half of your patients have a door to needle time less than 45 minutes. And you have achieved that. You presented 2 cases, and in one of them it was 45. But the shortest door to needle time has been achieved by Finland. Finland must be having fantastic system, and I think it is 13 or 14 minutes, definitely less than 20 minutes. That means they are just waiting like commandos. They are at the gate, and their system is so efficient. The moment it comes, they don't even talk to the patient and take him to a CT scanner and immediately give TPA. That is the challenge. We have to reach there. So that is one. Second thing is you raised interesting things that minor strokes, and you are perfectly right that this came about more than 7 years, that even if your NIHS is less than 5, it is not just important the number. It is important where from that number is coming. If it is coming from aphasia or if it's coming from visual field, then it's in the guidelines that you can thrombolyze it, right? In fact, I remember I had once a High Court judge's mother, and her only deficit, she did not have aphasia. She did not have a hemifield defect also like you. What she had is that her right hand was a little weak. And she was doing puja. And while doing puja, she suddenly found that she could not fold her hand. This hand went like this. Now, if you technically think, is it disabling or not? I think it is quite disabling for her. But it was not in the guidelines that if your hand is having pronated drift, it would become a non-disabling stroke because it was NIHS was just 2. So I told her daughter, who was a judge, I said, look, this is NIHS 2 and we need not thrombolize it, but it may progress, right? And and I think it is, if I was in her place, I would think it is disabling. If your one hand is weak, you cannot tie your button, you cannot wear your clothes, you cannot do your puja. NIHS is 2, but it's in the hand. And even if it was in the left hand, he said, you, sir, even though she was a judge, but at that time she was a patient's mother, he said, sir, what you think proper, you do it. And we thrombolized her against the guidelines. In fact, at that time it was clearly written that if it is 2, you should not thrombolize, unless it is aphasia or... And fortunately, the patient recovered. Otherwise, I might have had to go to the court. You know, I might have got a notice because I had taken the consent and all. But I think this issue was addressed by Pooja Khatri. And I think all of us know Pooja Khatri very well. She is the internationally renowned specialist of Indian origin. Her sister lives in Chennai. Even now, they are settled in Chennai. I met them in the last conference. So she did a study called PRISM study. And in the PRISM study, the premise was that minor strokes, minor disabling strokes. And what was the definition of disabling? The definition was that, you know, if you're not able to brush teeth, if you're not able to button, if you're not able to walk, there's some, basically if it interferes with your activity of daily life, even in the smallest. And if you take these small minor strokes, then what they found is that very small strokes, which are non-disabled, they could not, first of all, the problem is that the PRISM trial had to be terminated prematurely because they could not get enough numbers. But the result of that, based on those incomplete numbers, was that if there are very minor strokes, which are non-disabling, which itself is controversial, what is non-disabling? You should not thrombolize them. If they are non-disabling and if they are minor, and that non-disabling was left to the discretion of doctor and the patient. So therefore, thrombolizing these minor strokes got a little bit of a, jolt. That means there was something you should not thrombolize. There was that category. But in my personal practice, whenever a patient comes with any degree of neurological deficit, except probably a mild facial numbness, but even there also, I would probably convince the patient to get thrombolized. Because in neurology, every deficit is disabling. Very difficult to define what is disabling at all that thing. So I would thrombolize every deficit, even if it's a right hand dexterity, left hand dexterity, right dorsiflexor weakness. The only thing is whether if you have got a mild sensory deficit, would you thrombolize? I, for one, would thrombolize that also. But Meenakshi, what is your comments? Expert comments.
Sir, not experts, the comments. Sir, same experience I had once, sir. I did not thrombolize a patient who had only sensory deficits. And the patient haunted me for more than a year.
Yes.
Because sensory deficit persisted, sir. I told him it is non-disabling. And she asked for whom? Because it looks non-disabling for us. A numbness, a persistent vague sensory symptoms are always troublesome. And the point is, when you have a deficit, I think we should thrombolize. We do not go through that. Now, after that, I have never gone through the guidelines because the stressed fear of hemorrhage is not there because the volume of infarction, when it is very small, we know that it is not going to produce any hemorrhage. And after that case, any patient, anything NIHS is more than 0, I thrombolize. I don't hesitate at all. In fact, there was a paper about this concept of RIS, that rapidly improving stroke symptoms, whether we should really thrombolize these RIS patients. And what was seen is that in those patients where the investigators felt that the patient was too good to administer thrombolysis, whether we should do it. And more than 1/3 of those patients could not be discharged home. They had to go for a big way treatment where those facilities are available in places like US. They went there instead of going home. So it was not a happy ending at all for those risk patients. So I am up with the same, because we are taught by you probably, sir.
Yeah.
He will thrombolize. Now that you are told.
But you should take a consent of the patient and mention it. Explain to him, yes, would you like to walk with a sensory numb? Now, he may not improve. Now, let me tell you one more thing. After you have thrombolize, his deficit may not improve. That is a different thing. But you have done your bit. You have done your best to dissolve that clot there and to save him further. Take a good consent and all. It's better. It's always better to thrombolize than not to thrombolize in general. Remember that.
Sir, I beg my pardon to disagree a little bit.
Yeah, sure, please. That's what we want.
Minor strokes, I experienced. My residents also used to say when I was in AIMS, should we thrombolyze or not? So minimal motor deficit or facial, as you said, many patients, because cost was also an issue, so we did not thrombolyze them. And almost all of them improved within 2 weeks or 3 weeks. So my experience is mixed, and few patients deteriorated also because of the progression in the stroke. So I have both experience. Minor stroke improved within 2 weeks to 4 weeks.
No, you are absolutely right. Dr. Rai, you are absolutely right. Some will improve, some may not improve. The problem is we don't know who will do what.
True, sir.
So otherwise, you are right. So many times patients, I have told patients, you have to be thrombolyzed. And he said, I'll call my son in America. I will call my son. And most of the sons and daughters are abroad. Only patient is alone here. And we are there to decide, take their decisions. But by the time they think the patient has improved, so then we will not thrombolyze an improved, completely improved patient. But in others, since we don't know, therefore, I go on the side of thrombolyzing. But you are right. I completely agree with you.
I have not allowed myself to gain that experience, sir, because we are overtly enthusiastic and our residents do it also. As I told you, sir, here in our hospital, our emergency residents, we don't have neurology residents, we have emergency residents who immediately thrombolyze. Any deficit they are taught.
We should remember that we should not be surprised that this patient improved with or without thrombolysis. We should remember that the natural data is that if you don't do anything to a stroke patient, means don't give him aspirin, don't admit, just watch him. 30% of them will become normal at 3 months.
Yes.
Normal. 30. This is hard data. This is evidence-based data, 30%. When we are giving these thrombolysis and all, that figure becomes little higher. It may become 43% or 44%. That's all. It doesn't even become 100%. So we are only increasing the dots. So 1/3 of the stroke patients, particularly the minor ones, will become normal anyway. But the commonest stroke patients which progress are also lacunar strokes. The ones which we think the commonest, if you take motor progression, there are many articles of it. Which subtype progresses maximum? It's lacunar stroke. So the ones which look very innocent in the beginning don't remain so innocent by 24 hours, some of them. So that is the problem, that uncertainty of stroke. That is the problem. But some of them will definitely recover.
This weekend thrombolysis which you mentioned, I don't think it applies to our Indian people, I think, because all neurologists who take up thrombolysis, they don't care whether it is a weekend or and I do not think that we have the concept so much etched in our brain about weekends, maybe metros and things, maybe because we are small cities. There's nothing called weekend or weekday for us. Every day is the same.
Actually, I was out of station, sir. I was in my hometown, so I had to come back all the way and travel 150 kilometers just to attend the patient after thrombolysis. And the very same day, I have replaced my vial because I maintain these Tenectase vials in my clinic, sir. Because we don't know usually. And one more thing, sir. This is the 5th thrombolysis I've been doing only on Sunday, sir. So I don't know whether it is a coincidence or something, but if I get a call on Sunday, it's most of the times like thrombolysis only, sir.
So I think you should name your clinic as Weekend Stroke Clinic.
See, there is a paper from Vladimir Hachinsky's group which saw the differences in improvement between weekend strokes and weekday strokes. In fact, that is a data available because we don't publish often. Westerners publish, and for them that weekends and weekdays are totally different. And for all diseases, they have shown that weekend mortalities are higher. And Dr. Hachinsky's group, they published their data about how it is, and they have given some reasons also. And they're interesting to read also. They say that, number one, the stroke severity may be more because they may binge alcohol, they may binge drugs. They may come to the hospital late because they don't want to go to the hospital on a weekend and they may come late to you. and then your assessments may be late, less experienced physicians may be available, the number of times you will examine the patient will be less. So they're given certain reasons why the weekend, strokes are, quite difficult when compared to the weekday strokes. But in our setting, as for you also, we have nothing called weekend or weekday. Everything is the same for all of us.
But Meenakshi, that's very interesting. I think I would like to look for that article. But in a lighter vein, there's also data that when there was some, I don't remember where I have read it exactly, but I have definitely read it that there was some country, India or some other country probably, where doctors went on strike. They were on strike for about a week or so. And then they wanted to see the mortality and morbidity during that week when the doctors were on strike, and it was much less actually. Less people died and more patients recovered.
Sir, thanks to media, sick patient would not be coming to that hospital or that area.
Sir, I thought you would say the other way around. Paradoxically, they found that
everywhere it might have been announced that don't go to that hospital because there is a strike. So sick patient
maybe. Yeah.
So just like in COVID, when the normal OPDs got shut, the number of, the coronary, the MIs and all that reporting, they just came down. I was speaking to one of my friend in AIMS. He said, I'm not able to understand why suddenly people are having less MIs than otherwise. So it's just simply like that. But anyways, good cases. So any more discussions, Dr. Rai, Dr. Sundar, or should we call it a day?
No, ma'am, it's a very nice discussion, and sir gave a lot of bombarded with the information. So I am always waiting for calls, sir, even in conference also. So he's always, whenever he comes, he gives a lot of information.
Makes it light, all of us. Makes it enjoyable.
No. But that is just
stroke enjoyable, sir.
That is just. That's what you feel. But basically, it is me who keeps on learning. I have learned so much from this forum. I was so excited last time when you. Presented, one of the attendees presented IV thrombolysis in retinal artery block. I'm just looking for a patient. I'm not getting it. These data and all, they will never capture an individual patient. And we don't have enough forums where individual patients are discussed. Journals don't accept case reports. In conferences, nobody sends case reports. They all want data. And it is actually the case reports, the individual cases from which we learn. Basically, you see, this is a paradox. We read studies, clinical trials. The bigger clinical trials will have 20,000 patients, 10,000, but that will never capture that one individual patient. And unfortunately, the patients we encounter, they come to us one by one. We don't get 1,000 patient cohort to us and we'll say, no, aspirin is good for you because 700 patients improved with that. We get that individual patient. We have to treat the patient individually, but the data is collective. So that is a big, paradox. Therefore, forums like this are welcome. I think we should have more and more of them. I think you should do it. You should not do it only for next 6 months. You should do it forever so that we keep on learning from each other.
Thank you. Yeah. Thank you very much.
Thank you.
We are very blessed and fortunate to have you. And, sir, besides the case, our young neurologists are watching you all. And, I always, say this, that the doctor-patient relationship, the empathy part that you talk about. So our senior doctors like Dr. Subhash, Dr. Meenakshi, sir, who have been with us in this forum always. So many times we touch upon these aspects also, that it is just not a mechanical treatment you have to deliver. It's bringing in that bond, fostering that bond between your patient, how you communicate. All these are very, very important for a young generation out there to listen. And sir, I still haven't forgotten. I think in our second KT or so, you said that nothing succeeds like success. And today also, as soon as we just opened the forum, you said that. And the other thing you said is that we learn stroke by stroke.
Yeah.
And these are some things which are,
that is Miller-Fisher.
Absolutely. So they are permanently etched in our mind. Whenever I also come on this forum, I look forward to learning something new. So thank you very, very much for this wonderful.
Thank you, sir.
1 hour is very, very enriching.
I have two things, sir. Sorry to interrupt.
Please.
But, sir, one thing is we have, I just wanted to say, sir, I have maintained I have done my somewhere around 15 thrombolysis in NIMS, sir. So most of them were within 30 minutes, sir.
Oh.
But the best one was within 15 minutes, sir. The patient was known to me. I have called him to NIMS. So I have rushed him to MRI, where we have found a stroke, and then we thrombolized there in the MRI console itself.
So you have broken
within 15
Finland's
minutes.
record. You should publish it.
Yes, sir.
And
Yes, sir.
wait,
Thank you,
15
sir.
minutes is amazing.
Yeah.
Amazing. So that is possible that
Yes,
in
sir.
our country.
Yes.
Yes, sir. Yes, sir. But it has to have a strong EMS support, sir, or else the patient has to be known to us.
Correct.
That's the only way out, sir.
Yes.
Sir, one more thing, sir. On a lighter note, I have given the injection. Patient had a NIH of almost 7. His hand was not moving much, and his lower leg was completely down, sir. But as soon as I gave the injection, and 5 minutes I spoke to the attendants, and then I came back, and I was surprisingly found that his upper limb was almost like 4 minus, sir. Lower limb also he was sustaining, sir, like 3+. And the attendant had a strange look at me, sir. Is it the injection or patient improved spontaneously? I did not have answer, sir. So, but of your experience, how would you take this, sir?
This is miraculous.
Like,
Yeah.
the first time I have thrombolized like many cases at NIMS. Like, I have seen not much like you, but out of the cases that I have seen, this was the best case, sir. Best case that I have attended.
Yeah, but you see, this is called, in some patients, there is a dramatic effect. That
Yes,
is
sir.
called Lazarus effect.
Lazarus.
That is the term which they use, Lazarus effect. Lazarus effect means the dramatic, means the people who present, usually we hear these presentations from Americans only, and at least in the past. So the expression they use is that the patient walked up from the bed and started walking. The totally paralyzed patient walked up. And, so that's called Lazarus effect. But you saw people who use thrombolysis have to know. They have to know that the response to thrombolysis is not like that in each and every patient. You have
Yes,
to
sir.
know. When
Yes, sir.
when we thrombolized, when we started thrombolyze in 2000 something.
1995.
95 was in US, but here 2000 something. So we were one of the first in NIMS only. We were
Yes,
one
sir.
of the first we started.
Rupam sir used to tell us, sir.
Yeah. So then 2 became 4, 4 became 8, 8 became 10. And then there were some bleeds also. Initially, there was some massive edema also. And some patient died also after thrombolysis. So first we presented 50 patients. And in those 50 patients, there were some, as expected, 2-3 deaths and some bleeds. So Dheeraj Khurana, my very close buddy and friend from PGI, got up and he said, well, in our experience, nobody bled. I said, how many have you thrombolized so far? He said, 6. I said, your 14th patient will bleed. I said, you reach the figure of 14, he will bleed. And actually his 14th patient bled. And he told me, Kaul, you were so right. How did you know that? I said, no, I did not know that, but that is the data all over the world. 6% bleeds, out of which 1/4 will be fatal. So data cannot be wrong. So this we have to know. And while counseling the patient also, one of the things which we do in our youthful enthusiasm, we think we'll give TP, a patient will walk. And we promise it to patient. Some of them will
Yes,
walk.
sir.
Some of them will walk. Some of them will still have mild deficit, and some of them will die also. So this
Yes,
you have to know in your mind and take a
Yes,
shared
sir.
decision making,
Yes, sir.
right? Because that is realistic thing. That's what.
Yes, sir. True, sir.
Thank you.
Thank you, sir.
Nice. Once again, congratulations to both the presenters.
Thank you, sir.
Thank you, the presenters. Thank you, Subhash sir, for gracing this forum every time and enlightening our speakers, our young neurologists. Thank you, Meenakshi sir. You are an epitome of humility, if I would say so. Thank you very much, sir. We learn every time. We learn so much from both of you. Thank you, Dr. Rai, for gracing this occasion. I'm sure you would have had a great time on this forum, and we look forward to your presence again on this forum.
I would like to be part.
Yeah, sure. So we'll call it a day, sir. We'll
Thank
stop here. We'll meet again next month. And good night, everyone.
Good night.
Thank you.
Thank you, sir.
Namaste.